Good day, global citizens. Welcome to another episode of Bola Speaking. Different social media platforms. Basically, it's about the service we as global citizens received from health facilities. Now, talking about services, someone outside the health sector might not see a deficiency in the service him or I receives from the health facility, but as a medic, because I know, for example, someone like me or our guest, because we know what should be done, we can see a deficiency in it. But mainly, there are 2 points I want to share. The first point is, I discovered when I was pregnant a few months ago, that when I went to the hospital, like the consultant, because he knows I'm a doctor, like he's always happy to have me around, because then he could invite medical students to come and learn and teach them, because not every patient, even though it's a teaching hospital, because of the environment and also, because of mainly the environment and the type of institution, people don't really allow medical students or residents whatsoever to learn from them. So I see this as an avenue to talk to global citizens. Like in the next 10-20 years, basically, these are the people who will work on you. These are the consultants you'll be meeting. These are the attendings you'll be seeing. These are the old doctors, because sometimes you want old doctors. These are the old doctors you'll be seeing. So the earlier, the better. The earlier you allow them learn from you and not from ChatGPT, the better doctors they will be. The better their hands-on. So please, when you get to the hospital, whether you are in a teaching hospital or not a teaching hospital, if a doctor asks for a permission for a student to learn, if they can bring them in to show them how they work on you, please allow them, because they're the ones that will work on you and your family, your friends and family in the next 10 years, in the next 20 years. Another point I want to share, I think this is a good platform to share it, is when we go to the hospital, normally, it depends on where you are. So like New York, even if it's a small hospital, because of the population, you have a large amount of patients, let alone some places in Africa, from places like Kano, Nigeria, where you see, even to private hospital, you are seeing lots of patients, let alone a government hospital. So please try to make the work easier for the doctor you are seeing by even though the doctor wants to create rapport, try to make their work easier. Don't say unnecessary things, don't ask unnecessary questions. Like, you understand, even though they want to have all the information, like, make the work of the doctor easy. An incident happened a few days ago when I went to the pediatrician with my child. Because naturally, when I go to see them, I make their work easier. But this time around, something just told me, like, just say something to make her smile. And I could see, because she was already stressed coming in from another patient, I could see, like, when I said the joke, she was like, how are you? How many of you are living at home? I was like, we are just for living at home. And someone else was like, who else? I was like, the angels. The angels. And she laughed so much. So I laughing so much, it made me happy, and I saw the more love she gave to my child, like sense of humor, make life. Medics are not angels. Sometimes why they don't show you sympathy, because they know that you are there to use them. And they're also there, some of them are there for their money. So when they say that you care about them, they'll give you more care too, to whether you are the patient or to your child or your parents. So these are 2 points I want to share before we start.
That you can use also help support them manage their diabetes. And all this comes of backdrop of continuously seeing a growing population of younger and thinner people coming to hospital with diabetes mellitus, as contrasted to a bit of the elderly and more.
It's when I came to places like the Global North that I got used to seeing people with MD PhDs and seeing MD PhD as a norm. Like, from where I come from, Nigeria, it doesn't matter if your IQ is 200 over 100, like you have to do your master's before going for a PhD. 1.4 million. To what the statistics I got, by the way, you can counter it. It's about 1.4 million people living with HIV in Uganda. So when I read your paper, I appreciated, because for me to do medicine, I did my medicine in Kampala, which is the capital of Uganda, but I did spend 1 year in the
of the Western world. Then you may not actually want to call it a city, but if you're looking at it in the context of the developing Uganda, and in the context of the rural settings in our country versus the urban settings and the growing cities, and the kind of lifestyle and way of life and standard of living, then it really qualifies to be a city, because there is a
doctor, because I know you've done your, will I call it residence or internship? You've done your internship, you've worked in Uganda, you have a good work experience. Let me not say elaborate. You have a good work experience working as a medic in Uganda. How do you feel? Because one of the problems I face as a medical student is the patients not buying the drugs. And even my senior colleagues have been stressed by that. Sometimes patients not being able, because I was taken to the regional hospitals where you have Antoine and many patients, the rural setting, and put it that way. So how do you feel sometimes? Because not all. How do you feel sometimes when your patient can't afford a certain medication?
Most of the times, and sometimes the logistics are not in and you have to buy them. They find it really hard to make their way through the treatment and management plans. And it even becomes worse with increasing non-communicable diseases, because they're a bit expensive to manage. And you have this patient that needs.
I commend the government of Uganda for, in as much as the economy is, compared to all African economies, we are thriving, we are developing. In terms of HIV, I commend the government of Uganda for what they are doing, because when I was there, they would give money, they would give food to encourage HIV patients to come and take their medications. Uganda has stable electricity compared to a country like Nigeria. I'm not trying to insult Nigeria, but compared to Nigeria, there are some services and other things that Ugandans have. So I commend the government of Uganda in that aspect, making life a bit easier for their, making life a bit easier. Let me not sugarcoat a bit. Say you are working on patients. Sometimes 5 out of the 10 patients you have hepatitis or HIV or a combination of both. You can't say you won't work on them. So you just have to be careful. So one thing I thank God is I graduated from Uganda without having those pillages, or maybe when you are catheterizing, cannulating a patient, injuring yourself, going with HIV or maybe another hepatitis. As a doctor, have you, and when I was here as a medical student, I have interns who were on PEP, and I saw how sometimes the side effects of these medications, how it's like the kind of dreams they are having, how it affects their day. Into the paper. In the paper, lifestyle related risk factors like poor dietary habits, physical inactivity, obesity were discussed in relation to lifestyle of Ugandans living in the eastern part of Uganda.
A bit of hard question to answer, because most of the things are informed by good data culture, which we do not have, just like in many other developing countries. So if you want to talk about all-cause mortality, burden, morbidity, for various things, trauma and all that, they really require good registries, like in the hospitals or national registries, they require, very good population studies, but whereby you have that longitudinal data that talks to mobility, mortality, how it has changed over time, where such patients come from, and which regions of the country, for different things, trauma, cancer, diabetes, hypertension, which I realize that it has been very fundamental in these countries that are developed, because now it is helping them transition use of AI, machine learning, and big data, because they have the data, they have collected it over time. And it is easy to ask a question like, how is the morbidity and mortality all caused in the United States? Where is it better and all that? Because this data is there. But in our countries, that is very scarce and something that we are really just waking up to improve with all the implementing partners and all the grants that are really now coming in to strengthen data systems and but nevertheless, it's not all lost, because we have a few of wide population studies, national population studies, like the Uganda Health and Demographic Survey that goes on every 4 years. But we also have a national NCD risk factor survey called the STEP survey in countries across. We had the first one in 2014 and did another one in 2023. So that gives us a bit of information, maybe like on risk factors like diabetes, hypertension, obesity, physical inactivity, and health that where they are occurring and where gender differences and all that. So if a bit of that national data. But when you look at things like trauma, for example, I only know we have a Kampala trauma registry, so you can get a bit of information about trauma in Kampala. But if you wanted across the country, you may not actually be able to know exactly how is the trauma like in the eastern part. Most of those are in police reports, which come out annually, but it's not out of scientifically as much in the urban areas as it is in the rural areas, and it has been growing exponentially in either setting. And we have seen actually our rates of hypertension double from about 1.4% where it was national in 2014 to about now 2.6% in the last one done in 2023. So in the space of 10 years, that has doubled, and even this could be underestimated because, like I said, the data capture is not good. These are just one-off cross-sectional studies into the young people. So most of the people now who are getting hypertensive and diabetic are young, average age of 35, 30 years, and this is really terrible for a young population. That time when you're supposed to be energetic and contribute most to the economic growth of the country, you start grappling complications, stroke, poor sight, fatigue, and everything.